Good afternoon, everyone. Thanks for joining this another fantastic session on the Urotechnology. We haven't done the Urotechnology before, so in 2022 we are doing for the first time this topic. I hope it will be as informative as the usually our webinars every month last Saturday. If somebody wants to know how we have performed in the past few years, that we can know by how we are appearing today, either professionally or in the personal life. Similarly, Mahatma Gandhi said, if somebody wants to know how you are going to be in future, it depends upon what you are going today. So whatever work we do today is going to sculpt our future. Many thanks to the Triumvirate, as usual, Professor Bhaskar, Bhavan and Zishan for being the backbone for all the webinars. The amount of work they done for this international urology education is immense. Thanks for the opportunity for us. We have got a rainbow of wonderful faculty who has excellent caliber, not only as a great speakers and also in their own subjects. Purposefully this time I have tried to incorporate their own specific special interest, so the topics will be very interesting and informative. You all may already aware of the schedule today. We have very big topics and very latest topics to crack on. The first talk is on green light laser from Feras. I will share that in few minutes time.
Green light laser. Prostatectomy. My name is Feras Al-Jafari, a consultant urologist at NHS 5. I'm going to give you a short lecture today regarding green light laser, various modalities of using it, and some expert tips and tricks. A quick historical note, green light laser has been on the market for quite some time now, and initially it started with the 80 watt followed by the 120 watt, which are currently largely historical given the introduction of the 180 watt laser with the MOXIE fiber, which delivers more energy suitable for bigger glands, higher power, larger beam spot, but also causes less charring and allows a better outcome. From the EAU guidelines, we know that green light laser is hemostatically safer than TURP. We know that we have a strong recommendation to use green light laser as an alternative to TURP for the 30 to 80 gram prostates, and recommendation for that to be used for patients on anticoagulants. Now, how does it work? I'm not going to delve into the details of physics because this is beyond the remit of our presentation, but basically we're talking about an Nd:YAG laser with a wavelength of 1064. It passes through a lithium borate crystal. Two photons coalesce. The energy adds together, producing a single photon of a wavelength of 532, which basically is the laser that is coming out of the fiber to treat the prostate. The depth of penetration is quite important because we know that it goes no deeper than 0.8 millimeters, which reflects a safety profile as it's very unlikely to cause any perforation with green light laser, of course, unless if we are persistently remaining on the same spot. For good understanding of a good surgical technique, we need to know what the surgical dose is, which basically is the energy per unit volume. So we know that the green light laser is a divergent laser. So the closer we are to the tissue, the higher efficiency and higher dose we're giving per surface area. You have big bubbles which are coming towards you, which tell you that you are doing a good job. But the further you are from the tissue, the less laser you're delivering per that area, and therefore you'll have a superficial vaporization with poor up. The laser is side firing, deliberately divergent, so the change in distance does lead to change in tissue interaction properties and output. The perpendicularity of the beam is of major importance to get a good technique. Given that the laser is divergent, if you are not perpendicular on the tissue, you are not delivering the laser in the most efficient way. And all my trainees do know that I always talk about getting the fiber very close to the tissue, perpendicular to it, without losing contact with the surface that you are aiming to. The advice always would be, in my practice, not to titrate up the energy, just go high power right from the beginning, keep close to the tissue, sweep slowly, have a narrow angle, watch for the bubbles. The bubbles are your immediate feedback mechanism. You know that you're doing well if you're having big bubbles. And that also that technique, having been close to the tissue and slow in your swipe at points, can offer you better hemostasis. So lots of techniques have been developed, and Fernando Sancha has been one of the pioneers of delivering green light laser in a more innovative way. So classical vaporization is what most of us do, and most of us learned how to do at the early phases of our learning curve. Anatomical vaporization is a combination of classical vaporization and enucleation, but for those who don't have a morcellator and want to have a good cavity, green light enucleation is similar to any en-bloc enucleation technique using a different energy source, which is a green light. So classical vaporization, the way I teach it, the way I was taught it, it's always to start anterior channel. You see the black line where the anterior channel goes back at 1 and 11 o'clock back to just short of the sphincter. And that will delineate the superior aspect of your resection. And following that, the lobe is taken from top to bottom to remove the kissing lobes, which are obstructing the flow. And sometimes we need to use the fiber to push against one of the lobes just to allow us to open it. And at the end, you go to the bladder neck and open it, obtaining a TURP light. Now, anatomical vaporization does start the same as by following the same steps, but before tackling the middle lobe, identify the verumontanum and the paracollicular space, where usually in enucleation is the point where you lift off the lateral lobe of the capsule. So once we do that, with the help of the fiber as well, you can find that plane between the prostate and the capsule, and then you develop the plane going upwards as the middle lobe would have been delimitated So you'd go underneath that, and with gentle dissection, you'll be lifting off the middle lobe, your fiber underneath it, and then you'd be firing upwards to remove that middle, vaporize it. Now that's a technique which you would do after doing 30, 40, 50 cases, and you're quite comfortable with the use of your scope, fiber, and the tissue distance. Green light enucleation, as Herman says, enucleation is enucleation is enucleation. So if you want to do an en bloc technique and you have the green light laser, you can do that if you manage to identify the right plane. You start with detaching the sphincter anatomically from the anterior lobe with anterior early eliberation of the sphincter. We draw the line, the white line that Sancha as well describes, and most of the difference between holmium, thulium, and green light is that most of your dissection is blunt, but during the procedure you can vaporize as well, which would reduce the volume, and if you need to bail out, you can always use green light laser to vaporize the rest of the tissue. You'd use the fiber as well, the tip of the fiber, to create that space between the lobe, adenoma, and capsule. And at the end up with an en bloc piece, which you ladder and more select. Outcomes are from the Goliath trial, very well known and published, non-inferiority to TURP, with IPSS score similar, better safety profile, similar production. Recovery parameters are superior with shorter catheterization, quicker achievement of stable health, and less. The patient-reported outcomes are similar. Patients are happy. This brings us to the conclusions. I strongly believe that green light laser is a very versatile laser. It's very safe. You can use it in multiple techniques to adapt it to what the patient needs. If you have a high-risk patient and you want to vaporize, if it's it's an anticoagulated patient, you want to go for classical vaporization. If it's a bigger gland in a patient which you want durability, you would vapoenucleate, or you can even perform anatomical enucleation for the bigger glands, 80 plus, where your learning curve will not be hindered by you getting stuck, as you can vaporize as you go. Many thanks.
Thank you very much, Faraz. That's a very nice, crisp presentation, and thank you for sharing both the vaporization and also the enucleation techniques. That's very useful for our audience. Next, I invite upon Professor Raji. He is the scientific co-chair for the SIU and the past secretary for the Urology Society of India. Professor Raji, floor is yours.
Good afternoon, respected colleagues and the trainees, and I would first of all thank URO-GRIPP for giving me a chance to be a part of this today's session. I will be speaking on shockwave technology and its advances and future trends. Shockwave lithotripsy is an established treatment option for renal and ureteric stones. It has undergone drastic modifications for optimization of results. Though ureteroscopy is gaining in popularity, shockwave lithotripsy still remains a commonly advocated treatment option. Objectives my talk highlight the advantages and its limitations, to assess the current role, and to give an overview on advances in lithotripsy technology and treatment strategies. It was Dornier HM3, the first lithotripsy which was widely used, which has a large water bath for optimum shock coupling. It has a fluoroscopic imaging, ellipsoid reflector with small aperture, and an electrohydraulic shockwave generator. Three basic types of shockwave generators are used in the treatment. One is electrohydraulic, other being the electromagnetic, and thirdly the piezoelectric. Electrohydraulic is based on spark gap technology, produces vaporization bubble, which expands and later collapses, which produces high energy pressure wave, and then there is an ellipsoid reflector which focuses the wave to the focal point. Electromagnetic produces a magnetic field as a coil located in one of two places around a cylinder, i.e. the inside plane of a spherical crab on a flat exterior overlying a conductive membrane. Shock waves are produced when magnetic field causes repulsion of membrane waves, which are focused with a parabolic reflector or an acoustic lens. Electrohydraulic lithotripters needs electrode replacement quite often, whereas electromagnetic generators last millions of shocks. Piezoelectric shockwave is here the shockwave generation is by non-linear propagation. Capacitor fired through a collection of hundreds of piezoceramic elements which are positioned on a reflector. Each elements are then focused on same location like a satellite dish. The clinical parameters affecting shockwave lithotripsy outcome. First of all, the patient selection is very important. The other parameters include the body habitus, stone burden, stone composition, stone density usually assessed by non-contrast CT, stone location, anatomical factors, and technical factors. Obesity is associated with poor outcome because of factors like positioning is challenging as the focal length is in 15 centimeters range in most of the lithotripters. Further, the excessive fatty tissue dampens energy from shock waves as it travels to F2. Again, there is weight limitation on the lithotripter table, and further, skin stone distance exceeds the maximum focal distance. Stone burden has a significant role in the outcome. Better results are usually found in case of renal stones when the size is less than 20 mm and in ureteric stones when it is less than 10 mm. Larger stones should be best managed by alternative options like PCML. Stone composition, stones of different composition vary in the fragility. And again, it is found that stones of same composition respond differently to shock waves. Reasonable or satisfactory outcome can be found in cystine and brushite stones, even if less than 15 mm, and matrix stones fare very poorly to shockwave lithotripsy. Stone density, which is assessed on preaxial imaging, can predict the stone fragility and outcome. Clearance rates are best when the stone density is less than 500, and if the density is between 500 to 1000, clearance rates to the tune of 85%, and when the stone density is more than 1000 HU, the clearance rate significantly drops. Stones less than 750 HU need fewer sessions for clearance rate more than 80%, and stones which are above 750 HU needs multiple sessions to achieve a satisfactory clearance rate. Triple D score, that is stone density, stone volume, and stone distance, can augment the prediction of shockwave lithotripsy outcome. Good outcomes are found when the stone volume is less than 150 ml, skin stone distance is less than 12 centimeters, and the stone density is less than 600 HU. Stone location is an important factor in the outcome of shockwave lithotripsy. It has been found that clearance is quite challenging when the stone is located in the inferior calyx. If there is a 1 centimeter stone in the inferior calyx, the clearance rate is less than 60%. And if the stone is more than 1 centimeter up to 2 centimeter, the clearance rate can drop down to less than 15%. Further, shockwave lithotripsy for distal ureteric calculus is again associated with low success rate. Clearance rates are good when the stone is located in the upper ureteric and mid ureteric level. We have a clearance rate to more than 70%. Anatomical factors include the infundibulopelvic angle. The results are better when the angle is more obtuse. Length, if the results are better when the length is less than 5 mm and the width is more than 3 mm. Optimal rate to be advocated for better fragmentation and reducing time. The exact optimal rate is not clear, but it has been found that when the rate frequency is 60 to 90 shocks per minute have better results when the rate is more than 120 shocks per minute. Energy ramping is again important because one has to ramp up from a low to higher voltage in a gradual fashion. This will improve fragmentation and also allows better patient accommodation to treatment sensation. Usually started at 12 kV for the initial few shocks, then gradually escalate to 13 kV for the next 500 odd shocks, and then further ramp up to 14 kV for the remaining 1500 to 2000 shocks. Proper coupling of shockwave lithotripsy generator head to patient in an airtight manner, because this will minimize the amount of gas bubbles in the coupling media and thereby maximizing the energy delivery to the stone. Now, advances in coupling design resulted in shift from the water bath coupling to use a smaller coupling interface for better fragmentation and shorter treatment time. Factors influencing couple include the type of ESWL machine, gel used at the patient-generated interface. One should have greater volume of low viscosity gels. Method of gel application is again important. One should apply to the shock head first. And the patient factors, the frequent movement can result in decoupling due to lifting the back of the generator, which can introduce air bubbles into the coupling interface and reducing the outcome. Targeting, proper stone targeting key to shockwave success. Targeting to be confirmed at regular intervals in two planes. Technical innovations include wide focal zone shockwave lithotripters. These lithotripters are based on acoustic input, that is dimensions and pressures of the focal zone. Wide focal zone can give more efficient fragmentation. The only disadvantage being the high peak pressure will result in increased tissue injury. Improved acoustic lens design in electromagnetic lithotripter. There is a widening of the focal zone. It has reduced the degree of trauma and improved the fragmentation significantly. Dual pulse lithotripter. Here there is distribution of shockwave energy on two applicators. Shockwaves are delivered along separate paths. Dual shock sources can be operated and shockwaves fired simultaneously or in sequential manner. Acoustic field can be manipulated here to improve stone breakage and reducing the treatment time. Dual pulse lithotripter, limited clear data is available at the moment, but it has been found that the main challenge is creating adequate coupling to the stone. Future ideas include enhancing the action of cavitation bubbles, tandem shock waves utilizing piezoelectric source fitted to the EHL system with an additional discharge circuit to produce PE second pulse. HIFU, that is histotripsy with EHL, has brought significant reduction in the fragmentation time, and of late, fusion of technology with burst wave lithotripsy and ultrasonic stone propulsion. Burst wave lithotripsy and acoustic manipulation is a very novel, non-invasive emerging technology. Separately or synergistically fragment and reposition the stones. There can be again incorporation of an acoustic tractor beam recently. This is again an evolving technology for manipulation and full entrapment of macro objects, that is the stone fragments. Burst wave lithotripsy with a larger beam width has been found quite effective in fragmentation of bigger fragments to up to 12 mm. It has been found to be 2.8 times more efficient than the existing burst wave lithotripsy. Tissue injury can be detectable in a real-time basis. Ultrasonic propulsion and burst wave lithotripsy are found to be very safe, effective to treat stones transcutaneously. Now it is in clinical trials and is showing promising results. To conclude, shockwave lithotripsy is a well-tolerated, non-invasive procedure with reasonable stone clearance of upper tract calculi with low morbidity. Advent of modern semi-rigid flexi-ureteroscopic manipulation of upper tract calculi has surpassed shockwave lithotripsy worldwide. COVID pandemic has again shown resurgence of shockwave lithotripsy globally. Proper patient selection and consideration of technical aspects of shockwave lithotripsy are key to its success. Non-invasive nature of shockwave lithotripsy made it a desirable choice for patients. Future direction in fusion of technology with burst wave lithotripsy and ultrasonic propulsion has potential of safe and effective treatment and outcome in upper tract stones. Thank you very much for your patient hearing.
Thank you, Professor Rajiv. That was a very nice and detailed presentation. We are so grateful that you have brought in even the future prospects, because there was a period for almost 10 years, the advancement in the extracorporeal shockwave almost stalled. That's where the other advances in miniaturization of the ureteroscopes and other things superseded. But I think there is a role for the advancement or newer innovations in the extracorporeal shockwave. Thank you for joining us, and we will come back to you once we get some questions from the delegates. Our next speaker is Dr. Nikhil Vasudev. He is one of the pioneers in the robotic technology. He has done literally thousands of robotic surgeries, and he's going to talk on his most favorite subject, which is what is the future holding for the robotics.
So thank you very much for inviting me to speak on the future of robotic technology at the URO-GRIPP meeting. And I'm very grateful to the organizing committee and Anand for inviting me. The truth of the matter lies in the fact that, the robotic surgical market is rapidly expanding, and at the way it's growing, it is predicted that even the microsurgical market would probably have an accelerated growth at about 7.3%. And the amount of investment taking place in the robotic surgical market will substantially increase. So it's a very exciting space to be in. And, be it anywhere in the world, patients were bypassed non-robotic centers. And this is data from the UK, which confirms this, in which patient demand is probably driving more centers to get robots through. And certainly in Asia and India, you can see a lot of new centers getting robots. And this is not only uniquely down to the surgeon demanding robotic technology to be adapted in their centers. It is largely patient-driven because patients want the benefit of this technology. Now, my center, we have two dual console XIs, and we have a Versius robot. And we have a very high-level robotic fellowship. We have 2 fellow posts per year. And we offer an array of robotic procedures during the fellowship. But we also have a lot of collaborations at the University of Hertfordshire and internationally with the Buddy Goody Foundation to work towards ensuring that the technology with robotic surgery is not only available in the developing world and the developed world, but it really is put down to benefiting everybody who needs surgery. And I think that's the real dream and vision that we do share. This is a paper of mine that was published in 2018 in the Annals of the Royal College of Surgeons with my registrar, Andy Brody, in which we spoke about the future of robotic surgery. And in my talk today, I'm going to cover you a few important points with regards to current systems, new systems, my experience with some of these, the single port systems, and even nano robotic technology, which is on the rise. So Intuitive Surgical has been the market leader for many years. And, they've been in the market since the 1995s, and they did achieve FDA approval. And it's interesting to see that in 2000, they had about 18 systems worldwide, whereas now they are tens and, they're about at least 6,000-7,000 systems implemented worldwide, with a lot of patients having robotic surgery. But as time goes on, there may be a bit of an overlap with the legalities, and you can have some patent litigation taking place in which some patents expire, some new technology comes through, and obviously the different independent providers that are developing robotic systems will use this to develop their own technology. So this is something which we will see as time goes on, especially with technologies such as EndoRIS or stapling technology, which has a lot of legalities and patent laws associated with it. The next 5 to 10 years, in my opinion, will see newer invasive, minimally invasive systems being developed, a new push for single port surgery, which is cosmetically more viable. Also with natural orifice, transhumeral endoscopic surgery, and I'll share some data with you, but also non-minimally invasive robotic systems will be developed for drug delivery, which will be the real future where we see things. So this particular slide just talks to you about some of the new systems coming out, the Alpha-X system, the Versius system that I have quite a lot to do with. And I have just come back from India where I have precepted a few teams to get started with their CMR programs. The microsurge robot, the Hugo robot, and obviously the Verb robot coming through. So the SenseHands surgical robot from the United States is, you can see this is how the robot setup is. It's only originally developed in Italy by SOFA, and it's both FDA approved and approved in Europe. And the uniqueness of the system largely stems from its open remote console, so the surgeon doesn't have to be confined to the space when they're operating, eye tracking software, 3 HD, 3D glasses, and 3 laparoscopic board arms, which you can use the adaptability of the camera to shift anywhere. And it prides itself on haptic feedback technology, which they're working on. And, this is important because in robotics, we do not have haptic feedback. The only feedback we have is visual feedback. So I think it's an important technology to enhance and develop. It's been licensed to be used in abdominal, pelvic, thoracic surgery, but not in cardiac surgery. You have a lot of clinical trials which are taking place to develop systems which are safer. You do have data available, which is largely done in urology to your porcine models for partial nephrectomy. But the team is really working on the development of smaller instruments, such as 3mm instruments, which will be a game changer with surgery. Now, Cambridge Medical Robot is the Versius robot that is really on the rise in India, especially. I think a lot of systems have been sold. And the CMR robot has been in equation since January 2014. As time has gone on, you've had more adaptability for more changes taking place. But you can see the CMR system really mimics your endoscopic movements with your wrist. Tony Loftus, one of the engineers at CMR, is nicely demonstrating how the robot will mimic your hand movement and even do some endo-wrist activities. So the advantage of this particular system is that you can either stand or sit when you operate. This was the first sort of console trial that we did at ORSI in Belgium 3 years ago. And the instruments that you have are slightly smaller. They're 5.8mm instruments. All the arms are single cart arms. So depending on the case that you're doing, you may be in a position to use 1 arm or 2 arm or 3 arms, whatever your preference is. And the advantage of these arms are they're very lightweight and portable too. It allows you to have 7 degrees of motion. You do have some 3D HD glasses. It does have some haptic force feedback technology being developed. And each instrument can be used up to 13 times. So, that is what the company mentions. And this is what we've seen. And you can see down here with the development of how we set up, this obviously takes a lot of time to get going, but this is how they are, the different arms which you can adapt in place when you do a CMR surgery. Now, this is the paper of mine, which is just in press, in which we worked a lot on developing protocols for robotic prostatectomy in cadavers, and which we've been able to translate into human cases. I'll show you a video of live robotic prostatectomy. But I think a lot of push really comes from the fact that your port positioning has to change a little bit, whether you do a 3-arm robotic prostatectomy or a 4-arm robotic prostatectomy. And when I was in India this time, we really worked on the 4-arm robotic prostatectomy protocol. But the port positioning is slightly closer to the pelvis compared to your intuitive positioning. And also you can use 3 or 4 arms, which is exceptionally useful. It takes a little bit of time to get used to putting your instruments and exactly the correct positioning of where your arms need to be placed. So again, this is the 3-arm. And we've also developed protocols for 4-arm, where we've been able to do robotic cystectomies and intracorporeal conduits. Not quite done a neobladder yet, but this is what we're working towards. And the real advantage, obviously, as you're aware with the robot, is the 4th arm, which allows you to have additional traction on tissue to facilitate your dissection and operating taking place. The robot, so this is robotic prostatectomy, allows you to do complete cases without a problem. With CMR, obviously, this has a bit of a learning curve, especially when you've done intuitive cases. Most of us are intuitive users, and we're moving on to newer systems. So there's a bit of a learning curve associated, but the procedures go off fine. And I certainly haven't really found a problem being a user for both systems with regards to CMR. Obviously, a lot of development is taking place right now in the context of new implementation protocols worldwide. But certainly, the theme seems to be multiple robots, multiple specialties. So a very exciting time, to say the least, as far as robotic surgeons are concerned or robotic users are concerned. Now, we also have got the Hugo Medtronic robot, which has been introduced in a few centers, I believe in Chennai and Apollo. There was a case recently done, and Alex did a case in February in Belgium. But the instruments, again, they are different arms and different carts, which are adopted too. You have an open console. And again, you can use 3 arms or 4 arm, whatever suits your convenience. So fairly similar to the CMR way of working, with different arms being put through. But again, this depends on surgeon preference and what you're trying to achieve. And lots of newer trials taking place, especially in South America, with the Medtronic robot. The microsurge robot from DLR Systems in Ireland and Germany is basically a concept. This was licensed to be used in Ireland in 2013. And Medtronic is sort of developing this technology also, in which you basically attach your robotic arms to the patient cart, to the patient bed. And this allows you not to have bulky arms come through. This may be a new beneficial way forward for thoracic surgery or head and neck surgery, where you may be able to place smaller arms on the patient bed and operate instead of having to drag carts through. And the visualization units can be plugged in. Obviously, there is no indications for docking or undocking. This, again, has 3 degrees of motion, haptic feedback, which is slightly different because it's impedance control mode feedback. There's no FDA or CE approval yet, and I think the first trials are scheduled to take place in 2020, but because of COVID, they've been slightly delayed in India. But you can see that this sort of robot may be the way forward with regards to certain situations where you may not have as much space to operate, where you might want the instruments closer. And certainly, this may be an outpatient facility robot being developed in due course. So it's fairly exciting, to say the least. Now, the Revo robot in Korea, there's been a few publications from my colleague, Hugo, and essentially what you've seen down there is that your robotic placement of ports can take place similar to the Da Vinci console, but the main difference is that you have a grip controller as against a finger type of controller during robotic surgery. The Verve surgical system has gone a little bit quiet. This is from 2 giants in the technology field, Johnson & Johnson and Google, so I don't think it can get bigger than that. But the aim is to create something called an SRI M7 system, which is allowing a lot of robotic autonomy and machine learning, so a lot of artificial intelligence thrown in. And Stanford is heavily involved in the development of this research project. But there's a lot of corporate secrecy associated, as you can imagine, with this, because the concept of robotic surgery with Verve is slightly different. They want to sort of install these with telesurgery. They want to put them on submarines, on space aircraft. So it's very exciting. But what we have from Google and Verve is a similar concept in which the arms are attached to the operating theater table. So this is what it looks like. But again, it's gone a little bit quiet, but I'm sure they're working on more prototypes and protocols to come through. Now, single port robotic surgery obviously offers you the benefit of not having to make multiple incisions. You have a single incision. And, this has been proven to be useful by my friend and colleague, Jeremy in Hong Kong, and Jihad Kok at the Cleveland Clinic, where they're doing a lot of single port surgery. There's a bit of CE marking in Europe, which is an issue, but I'm sure Intuitive will overcome this with the legalities associated. But essentially, the advantage of single port surgery is that you have lesser incisions, you have an improvement in your cosmetic outcomes, and potentially because you have lesser incisions, you have lesser pain. Now, the disadvantage is obviously those of us who've done laparoscopic single port surgery do understand that poor ergonomics can be a problem, instrument clashing can be a problem, and retraction can be a problem, because in robotics, retraction is a very important part of how you operate and how you do surgery. And the lack of space for the surgical assistant to come in may be a problem too. So the SP1098 Intuitive system is a single port robot. It has a 25-meter port access. It has multiple articulated arms. It's very slim and very, very unique. It has a new cleft system on your console that you need to get used to. But, FDA has approved it. Multiple centers are using it. But certainly in Europe for the moment, we have limited evidence. We don't have it available because of CE marking, but I'm sure this is something which will be overcome. But I think it's exciting, especially for cases such as pyeloplasty or head and neck surgery, or even natural orifice surgery might be contemplated with the single port robot. So I think watch this space, because this is the next big thing on the way through. Additionally, you do have different robots, such as the SurveyBot, which is developed by the Trans-Entric system of the United States. This is an upgraded system from something called the Spider platform. The controls lie within the sterile field. You have 2 laparoscopic camera holders, as you can see in the video. The surgeon wears 3D glasses. The FDA did reject this. There's a reapplication coming through. But I think, China is where the marketing is taking place, and they have limited data on cholecystectomy with this procedure. But again, this is basically enhanced laparoscopic maneuvers in which the surgeon has to orient and move quite a few arms during surgery. But again, for gallbladder surgery, this may be, or a hernia operation, this may be a very sensible way forward to adapt to. Now, even when it comes to your sport robots, these are essentially single port orifice robot technology called sport technology, developed by Titan Medical in the United States. You have an open console touchscreen similar to the single port robot that we use, but these only have 2 arms as against 4 arms. And the FDA approval is awaited. You have some preclinical studies which have come through for prostatectomy in February 2018, but after that, nothing much was published. But I think, a 2-arm prostatectomy may be a little bit challenging with a single port robot. But I think the 4th arm, if it's implemented with your single port robot, may have a strong role to play. So again, a lot of excitement taking place with your single port robot. You have newer robots being developed from the Mevo technology, which is miniature in vivo robots, and a lot of investment, significant investment taking place in which the incisions are smaller and they can be rotated. They're multi-quadrant. I've seen one of these. It's pretty amazing as to how amenable it is to go to different parts when you're operating as a part of just moving the main fundus of your instrument to orient to multi-quadrant surgery. So very exciting, and definitely in pediatric surgery, this may have a strong role to play. Now, there's a lot of talk about the NOTES operation, which is natural orifice. So this is the video from Singapore, in which you have a master-slave configuration, but instead of having this in the context of a robot, you do have a lot of transluminal endoscopic robotic surgery taking place. And the composition of these instruments essentially is a gripper or a cautery hook or another biopsy forceps. You have some haptic feedback, and human trials are taking place in Singapore, especially with endoscopic natural resection. Looks a bit clunky, the slightly older video from NUS, but a lot of development taking place. The next way forward is something called natural orifice surgery. So again, you have flexible endoscope or ISIS robots, ISIS scope robots from Karl Strotz, endoluminar robots, and you have Japanese robots called the Scorpion robots coming through. But you can see that this basically uses the same apparatus of animals that have basically 2 jaws when they operate to grab and catch. This may be the way forward with natural orifice surgery. Now, you have some novel non-robotic minimally invasive surgical systems taking place in Bhaskar, who's a world-leading endourologist, will probably think about the Elmet robot from Turkey, which really is useful potentially for flexible URSs to prevent recurrent stress injuries to surgeons who use the flexible URS a lot. It's been CE approved, and it has touchscreen technology. It reduces potentially the risk of a surgeon being so close to the patient, so you don't want to really get exposed too much to radiation. And there's some very good data from this robot because it's very steady, and I think it does achieve good stone clearance rate from the data which has been published. So again, it's been in the market for a while, and probably some endourology units in the world are already using this robotic system. The other newer, most amazing technology which is coming through is nanorobotics. So nanorobotics basically will allow you to propagate small robots, to target therapies for drug delivery. And these are propulsion-based robots, which use something called micromotor technology. And even with nanosurgery, this is more indicated for patients who have tumors, which are deep-seated, deep brain tumors, where it may not be easy to access. So you can actually use nanoparticles, imaging guided delivery of drugs using robots. So, there's some data coming through. You have nanorobotic ultrasound guided surgical therapy happening. And you also have something newer, which has been published on micro digger technology, which is basically cell-based therapy. So other technologies obviously keep developing. We have an integrated table that we use. It's absolutely amazing. And robotic stapling has obviously changed the way in which we, in my robotic intracorporeal program, which is neobladders and cystectomy, I just do robotic stapling now with the XI system. It's very quick. You don't have to depend so much on your assistant, and it really allows you to have, a 27-degree or a 54-degree movement take place with stapling using a 45 millimeter or a 60-degree cartridge. So lots of excitement with this sort of technology. My research at the University of Hertfordshire is predominantly low pressure, but I also do a lot of work on haptic feedback research because I think haptic feedback is important, especially with finesse surgery such as transplant surgery and anastomosis. And I think that will be the next phase forward with the future of robotic surgery, where you'll have systems which have haptic feedback technology available. My paper is available at the Journal of Robotic Surgery. So just to conclude up, the past 4 years have really seen a lot of systems coming through worldwide. The future systems coming through may shift the current paradigm of the competitive market, in which the cost of robotic systems may drop and availability of robotic surgeries may increase. The exact cost of individual systems is yet to be confirmed, but the market is definitely growing. The next 5 years in robotic systems will see at least 2 to 3 new systems being approved, maybe more will be approved. I think approval takes a little bit longer with the FDA, but with CE marking, etc., it's a little bit quicker. And Asia is most likely to benefit significantly from this technology, as the whole drive right now is to allow patients to benefit from technology as against be hindered from the cost of technology. So thanks very much for the opportunity, and I hope the rest of the meeting goes well.
Thank you, Nikhil. That was a wonderful presentation. And in fact, I can say to a certain extent, you have taken us kind of time travel, and it feels like we have traveled to 2050, if not maybe even like 40, 50 years of technology you have brought in. I'm so glad to see that you are able to bring in the nanotechnology and also the robotics in relation to the endourology. It's such a very, very wild field. Thank you for the in-detail presentation. I'm sure the audience will have some interesting questions, and we'll come back to you later. Next, we have a very interesting presentation on interventional urology by Dr. Salil Karkanis. Urology, even though is a quite independent and a well-established subspecialty, we still depend upon the intervention radiologist, and in our iTRUE webinars, we try to invite some specialists from other specialties also, so that there is something always there to read and learn. So let me share the presentation from Dr. Salil Karkanis.
A big hello to everyone. Thank you for inviting me. I'm happy to give my talk on intervention radiology technology in urological patients. My name is Dr. Salil Karkanis. I am a consultant intervention radiologist working in Queen Elizabeth Hospital in Birmingham. Over and above my general IR practice, my areas of subspecialty interest are those of hepatobiliary and genitourinary intervention radiology in a tertiary care setting. So as we know, technology in this day and age forms an important pillar, not only in intervention radiology, but in other specialties as well, especially with respect to urology patients. It facilitates diagnosis and treatment. Any improvement in technology allows improved visualization and targeting during the procedure and allows reliable and effective treatment. Now, rather than ramble on for 8 minutes, I thought I'll just divide it very basic sections of urological emergency technology, technology used in elective settings, and technology in uro-oncology. So the biggest group in an emergency setting is that of sepsis. You have a pyonephrosis or a renal abscess or perinephric collection, and you need to place a drain. The drains we use typically are polyurethane locking pigtail drains with a hydrophilic coating. It's got holes at one end to drain and a locking mechanism at the other. You place it into the abscess. It allows you to drain, and when it's all done, you take it out. Simple. In the emergency embolization, obviously, we are trying to stop bleeding almost typically. This is in the setting of trauma or iatrogenic injury. Once we've obtained diagnostic angiograms, the technology that we would use would be with respect to the embolic agent that we use. Now, obviously, these are the typical embolic agents, but not necessarily the same ones, but we try and use these. So the most commonest embolic agent is that of using coils. Now, the coils that we're talking about are really fine coils made out of platinum. And the idea being that you are inserting a metal foreign body within the bleeding blood vessel and initiating local thrombosis. Some of the coils can have these little fibers around it, which you can see in the image, and that allows or enhances thrombosis, quicker thrombosis. Sometimes when we have to embolize a larger field where single coils may not do the trick, we use gel foam, which I'm sure you know, it's gelatin sponge, and we make it into a slurry by mixing it with saline or contrast and inject it through the catheter. That causes embolization, which is up to 4 to 6 weeks long, after which the vessel recanalizes, but it works quite well in the emergency setting. In a more elective setting, for example, in situations of elective renal mass embolization, or for AML, for example, or prostate artery embolization for BPH, once we have got good pictures and we've got the catheter in the right position, we use slightly different embolic agents, which again, not typical, but this is what we typically use. So we would use polyvinyl alcohol particles, which you can see in the bottom right image. They can be of varying sizes depending on how deep you need to embolize in the vessels. They can be as small as 40 microns or as large as 1,000 microns. And as you can see in the image on the right top image, once the particles are injected, they flow with the blood and occlude vessels at varying levels depending on the vessel size and the particle size, causing necrosis and embolization. Sometimes we need to use liquid embolics for embolization. So one big group is that of Onyx. Onyx is a brand name, but what it effectively is ethyl vinyl alcohol mixed with dimethyl sulfoxide and tantalum, and that gives you this black resinous material which you inject through the catheter and causes cast formation inside the blood vessel and causes embolization, and allows you to get deeper into the smaller blood vessels, which coils don't let you. Similarly, another liquid embolic is glue. I'm sure as surgeons you know that. It's cyanoacrylate, N-butyl cyanoacrylate. So we use that glue, mix it with a lipiodol, which is poppy seed oil, which gives a blue-colored liquid, as you can see in this syringe, and that gets injected in the blood vessel and stops and causes the embolization. In a uro-oncology setting, the biggest group is that of image-guided ablation in setting of renal cell cancer or prostate cancer or adrenal metastasis. And the big technology groups that you should know about are radiofrequency ablation, microwave ablation, cryoablation, and irreversible electroporation. All of these have their own uses and their own disadvantages and limitations, which I'll try and touch upon. So the biggest group that you would have heard of is radiofrequency ablation. This is the longest standing ablative technology that we know. It's widely used, has the longest track record. Here, when the probe is placed in the mass and switched on, you generate local radiofrequency waves that cause local vibration of the water dipole molecules, causing a slow rise in local temperature and eventual coagulative necrosis. In all ablations, we try to ablate with a margin of approximately 0.5 to 1 centimeter, thereby simulating surgical resection. The reason why this is currently considered as slightly older technology is because it is time consuming. It is susceptible to heat sink if you have any big blood vessels close by, and the local charring that it causes can cause high impedance and eventual suboptimal ablation, which brings us to more current and slightly improved technology called as microwave ablation, which is what we use in our center as well, and most centers which have upgraded use this technology. Herein, the probe that we use in the mass is effectively behaving like an antenna. When you switch it on, electromagnetic waves cause, once again, local molecular agitation and temperature rise and eventual coagulative necrosis. In microwave, however, the temperature rise is more rapid. It can attain a higher temperature. It provides more uniform and predictable ablation zones, so you can ablate with a little bit more certainty. And it is less susceptible to heat sink from blood vessels that are running close by. The next technology that we have is cryoablation. So effectively, it's still ablation, You have replaced heat with freezing. Why would you do that? If you have a central endophytic renal mass where you don't want to damage pelvic LCL system or ureters that are close by, you would use cryoablation, which is more forgiving. It causes in situ freezing and devitalization of tissues with a variety of mechanisms, but the most immediate and important one is that of intracellular and extracellular ice formation that causes cell death. This can be applied and controlled precisely in the ablation procedure. That's why it is quite, people prefer this, and it is quite well visualized on CT scan as well as ultrasound. So people like this ablation modality for that reason. The final technology that we have is irreversible electroporation, where we are generating high energy electric field that causes irreversible nanopores in the cell membrane and causing cell apoptosis. It's a non-thermal technology, which means that it protects any adjacent normal structures like ureters or pelvic LCL system. It is not affected by heat sink. However, the needle placement has to be precise, so it's quite time consuming. It can trigger cardiac arrhythmia, so you need to gate it with the cardiac cycle, and it can cause muscle spasms when you ablate, and therefore you need an anesthetist that gives you good muscle relaxation. It's also a costly technology, so it's not your workhorse ablation technology which you can use every day. So I hope by touching upon by my presentation, I've been able to give you an idea about the technology that we use in intervention radiology, especially with urology patients. It's important that you as referrers and we as people performing the procedures understand the technology, know its limitations and its applications. And I hope this talk gives you an idea the next time you go down to intervention radiology or ask your intervention radiology colleague to perform a procedure. If you need to reach me for any questions on social media, that's me there.
Thank you, Salil. That's a very in-detailed presentation. For the first time, we have the opportunity to know what is happening across the corridor. So next time when we are referring a patient for any intervention radiology procedure, we can even explain to an extent that what we exactly need and what kind of energy sources, and we can understand them better. I'm sure this will be a single source, very in-detail presentation for the registrars preparing for their whether it's a written examination or the Viva examination. Next in the lineup, we have Emika Ali. He's going to discuss us the technology behind the lasers, one of the talk of the town for more than a decade now. Let me share his video.
Hello, I'm Emeka. I work at the University of Birmingham, and my talk today is on laser technology in urology. My apologies for not being here in person. I hope you find this presentation useful. So as an overview, we will look at the properties of light to allow us to understand some physics behind laser. We'll look at the properties of commonly used lasers, application of laser in urology, the physics behind stone fragmentation, and we'll touch briefly on the newer laser technology, and we'll wrap it up with a few points on laser safety. So some historical perspective. Albert Einstein first proposed the theory of stimulated emission in 1917. This concept is different from spontaneous emission, and we'll come to that later. Theodor Mayman is credited for invention of laser in 1960. He was a physicist in America. And the first clinical application of laser was in 1961 during ophthalmology procedure. Since then, there's been rapid evolution and research in this area, leading to what we have at present day, where laser is an integral part of our day-to-day urology practice. So a bit on the properties of light. Light, as we know, is both electromagnetic wave and also has particulate properties. as a wave, it's got wavelength, amplitude, frequency, traveling at the speed of light. The visible light spectrum is actually a narrow bandwidth of the electromagnetic spectrum, ranging between 380 nanometers to 730 nanometers. So on this slide, I've tried to summarize the complex physics behind laser. Essentially, most atoms or molecules will exist naturally in a ground or low energy state, with only a small proportion existing at high energy level. By adding energy in the form of electricity or light, atoms get elevated to high energy levels. To return to ground states, they need to emit the absorbed energy in the form of electromagnetic waves or photons. And the emission is spontaneous, and it's different from the concept of stimulated emission. So on this slide, I've tried to explain the physics behind laser, where a laser medium is contained in a laser chamber. The laser chamber has reflective surfaces. Energy applied to the laser medium leads to release of photons, which is trapped and reflected to bombard more atoms in the laser medium. And the cycle goes on up to a point where a higher proportion of atoms in the laser medium exist at a high energy level, a situation known as population inversion. The lasing chamber has an aperture that allows light of a specific intensity and wavelength to escape. Hence, the laser beam is born. The laser beam is monochromatic, collimated, and coherent, which are the properties of laser. In urology clinical practice, laser can be used for stone fragmentation, soft tissue incision, resection and ablation, tissue welding, and hair removal. So this table summarizes the properties of the commonly used laser in urology, specifically the wavelengths and the tissue penetration, and also where we apply them in clinical practice. On this slide, I've tried to summarize the physics behind laser stone fragmentation. But essentially, laser will interact with matter, and when it comes in contact with matter, it will either get reflected, absorbed, scattered, or transmitted. When laser energy is absorbed, it leads to photochemical, photothermal, and or photochemical effects, or a combination of all this. The mechanism that underpins stone fragmentation involves deposition of laser energy onto the stone, as well as deposition of energy to the water molecules surrounding the stone, leading to, so when the laser energy is impacted on the stone, it leads to photomechanical and photothermal effects. Photomechanical effects will result in transient stress, shear forces, leading to micro fractures and spallation. Photothermal effects will raise the temperature above the breakdown temperature of the material, leading to ablation. When laser energy is absorbed by the water molecules around the stone, it leads to rapid expansion and collapse of water bubbles, resulting in shock waves, formation of microbubbles, microjets, which result in stone fragmentation. So it's a combination of two mechanisms that lead to stone breakdown. In clinical practice, you could either dust or fragment stone. Some stone surgeons are strict dusters or strict fragmenters. I utilize a combination of both. But if you want to dust, you want to deploy low energy, high frequency. And if you want to fragment, you want to use high energy, low frequency. Popcorning essentially involves deploying a laser in, for instance, the calyx, where the stone then bounces around the laser fiber in a popcorn fashion and essentially disintegrates. So more recently, there's been advancements in laser technology. MOSIS technology, as the name suggests, involves splitting of water like the biblical Moses. Essentially, this technology emits laser pulses of two peaks. The first peak will split through water, and the second peak allows direct administration of laser energy to the stone. A paper published by Ibrahim et al. At the Canadian Journal of Urology demonstrated superiority over the standard laser machine, with nearly 20% reduction in procedure time, 50% reduction in rotary portion, and 33% reduction in fragmentation time. So to wrap it up, I thought I'll touch briefly on laser safety. And the laser energy has inherent risks of burns and damage to the eyes. So it's important that laser is deployed in a safe manner. So there needs to be a designated laser safe theater with laser signs, automatic doors, non-reflective surfaces. There needs to be a laser safety officer who is responsible for laser safety, as well as the surgeon. Both the surgeon and the laser safety officer need to be laser trained. The number of staff in theater during laser surgery needs to be limited, and everyone in that space has to have a laser goggle on. And if you're not using the laser machine, it needs to be put on standby. So I'd like to conclude by saying that advancements in laser technology means that today it is possible to operate through natural orifices and channels in a manner less traumatic than the scalpel or a surgeon's hand. Thank you very much. These are my references. Once again, my apologies for not being here in person to take the questions, but I'm sure the faculty will entertain and hopefully answer any questions that you may have. Thank you very much.
Thank you, Emeka. That was a very in-detailed presentation, and the presentation itself is very self-explanatory and clears all the doubts. Next, we're going to have a presentation from one of our very senior faculty, Professor Hamad Atkar. He is the HOD and Professor of Aga Khan University from Karachi, a very well-known person in the Pakistan region. One of the aim in iTRUE is to invite the specialist beyond the borders. I hope we are achieving that now. And before heading into his presentation, there is a question from one of our participants. What is the time taken for the green light enucleation of the prostate in a moderate-sized gland? It's quite difficult to answer with the term moderate-sized gland because we need to have the exact size. For example, if it is like 100 cc prostate with mosylation, it should take easily 2 hours minimum, because mosylation as such, irrespective of the technology, whether it's a holmium or thulium or green light enucleation, takes the same time. But if I'm correct, green light takes slightly longer time for appropriate coagulation. And holmium really scores best with the coagulation because of its intrinsic properties. Please keep posting the questions. We will try to answer them in between the presentations. Now let me invite Professor Hamad Atkar. He is going to discuss on the technology behind mini PCNL, one of the very favorite topic, not only for me, even for a lot of faculties. Cheers.
Thank you very much for this very kind introduction and invitation to present in the 26th March iTRUE webinar. I congratulate Mr. Nindakumar for his efforts for teaching and training of colleagues in urology. So I'm going to focus on advances in technology with the miniaturization of the percutaneous nephroscopes, and particularly focusing on the stone retrieval. I am Hamad Athar. I'm professor and head of urology at Aga Khan University in Karachi, and this is where I work. So if you look at the recent guidelines, and these are the ones which have very recently been issued a couple of weeks back on urolithiasis, things have not changed over the last many years. We still see that SWOL, RIRS, and miniaturized PCNL in this order are considered as the options of treatment for up to 20 mm stones in the kidney. If you look at the data between the recommendations for less than 10 mm and 10 to 20 mm stones, SWOL is considered as a first-line option for smaller stones, and also for stones in the 10 to 20 mm category, whereas endourology with RIRS and PNL has other options. For lower polar stones, again, if the anatomy is unfavorable, endourology is considered as an option. If the anatomy is favorable, then SWOL is an option for up to 20 mm stones, even in the lower pole. So these are interesting recommendations, and I'm sure things will change as the endourological revolution brings in more sophisticated equipment for stone clearance. One of the problem that we face with RIRS, which is considered as now the new workhorse of endourology for small and moderate-sized stones, is that sometimes you need multiple procedures, or at least you need one procedure for placement of stent. Stenting post-procedure is again something which is a bit of a bother for patients. Per-operatively, we see that longer operating times can result in significant rise in intrarenal pressure and related complications. Use of laser, as we know now, that increases the temperature and can cause thermal damage to the mucosa. The higher equipment and disposable cost is another important factor, but more importantly, the stone clearance, particularly with the stone, so-called stone dust, which is sometimes more than the dust itself, is a bit of an issue with RIRS. The percutaneous procedure, which is until now reserved for larger stone burden, have seen significant technological advancement since its first introduction about 80 years back, over 80 years back, by Rappel and Brown, who first described removal of a kidney stone using a cystoscope, using a 26 French cystoscope. It wasn't until 35 years later that Van Stom and Johansson first removed a stone and performed a procedure which we now call or recognized as PCNL. The German urologist Peter Alken developed 20 and 30 Charrier nephroscope with Karl Storz, a German endourological manufacturers. Hilal, probably about 24 years back, entered us into the era of modern MIS with miniaturized PCNL when he used a pediatric cystoscope to remove stones using a 10 French cystoscope. And since then, we have seen one innovation after the other, so much that now we have as fine equipment as a 4.85 French micro PCNLs or micro perc. We're using a 0.9 mm nephroscopes. So that's really amazing evolution of technology over the last so many years. I'm going to talk about two procedures and particularly focus on the fact that how they utilize the system to retrieve stone fragments. And so end of the procedure, you are completely stone free. You can do a CT scan within 15 minutes, which show no stone fragments. And these two procedures are the one described by Dr. Zhang from China. This is called super mini PCNL, and this utilizes a 14 French outer sheath and a nephroscope, which is specifically built to have irrigation channel as well as suction channel. And the suction is attached to negative pressure. The whirlpool created by this irrigation channel, which is in the outer part of the external sheath, creates a little whirlpool which pulls the stone fragment into the inner sheath, which is a wider bore part of the outer sheath. And this is attached to a suction, and this suction device can actually retrieve all these fragments so that at the end of the procedure, you have absolutely no stone left. Now, for stones which are larger and what cannot be sucked in, what you need to do is to withdraw your nephroscope, and these stones then can come up to the angle where these stones are sucked into the negative irrigation bottle. End of the procedure, what can happen is that the stones are completely removed and all stone fragments. Typically, they don't require any internal or external stenting. A very similar procedure is described by Dr. Desai and colleague with using a German manufactured scope called an ultra mini PCNL, which again is a similar device, which also utilizes a form of a suction system. This is an end-on view. The smaller hole is for the 1 mm nephroscope, and the outer sheath, which is a bigger lumen, is for the suction and irrigation of these stone fragments. So this nephroscope, which is a 1 mm telescope and suction and irrigation system, is introduced into the kidney. You can use a 365 micron laser fiber to fragment all the stones. And these stones are then ultimately sucked back into the system using the innovative device, which creates a little whirlpool, and subsequently all the stone fragments are retrieved back into an end of the procedure, patient stone free. So typically they don't try to dust the stone, they try to break it with little fragments, and these fragments are up to 2 or 2.5 mm, and they can be easily retrieved. So in summary, Ultra Mini and Super Mini PCNL provides technological advancement for safe and effective fragmentation, removal of small to moderate sized kidney stones, and all this can be done in an ambulatory setting, which is really ideal.
Thank you very much, Professor Attar. That was a detailed presentation on mini PCNL. You have covered almost all the important advances in the mini PCNL, including various small techniques, and thank you for all the short videos also. They're all very useful. Next, I invite Madeline Moore. She's going to discuss another very innovative technology on disposable scopes. I'm sure that this technology is not available in many of the developing countries. And even in the developed countries, we have a lot of questions in this, like about the impact on the environment and the cost involved, etc. I'm sure Madeline has answers for everything. Madeline, floor is yours.
Thank you so much for the kind introduction. I feel very humbled to be a part of such a distinguished faculty. So very much appreciate being invited. So I'm going to go through in about 10 minutes, which is quite a hard task because this is actually quite a large topic on the disposable cystoscopes. So I think we all use cystoscopes in our practice. It's a core part of our urology day-to-day life. And what I'm going to cover today is the scopes and what are the applications of disposable scopes, what our current literature is saying, what this actually costs, and as you mentioned, the environment. Are we just adding fuel to the fire here? So I'm just going to go through the couple of scopes that are currently on the market. You've got the Ambuscope and you've got the iCRIS scope from Coloplast. These are the main two that I've actually come across in my practice in the UK. And as you can see, they are incredibly lightweight. They come in a packet that you can carry around, and they all have this disposable flat screen portable TV that you can just plug your scope in without the need for any light source or any extra equipment. There's also an alternative called the NeoFlex. Not as much literature has been published on the NeoFlex, so I've not included this as much in my literature review. So why is this a nice thing to have? Well, it being disposable means you can literally just grab it off the shelf. And it's now really moved the flexible cystoscopic practice from being in an endoscopy suite to really being an office-based procedure that can be predominantly run by nurse specialists. It's actually shown in papers to have freed up the endoscopy suites for other specialties, or even helping us with our bladder cancer capacity issues, which have been a particular problem during the COVID-19 pandemic. It's also, although only some of the scopes have been licensed for ureteric stent removal, some studies have started to show that it has just as much efficiency and efficacy in diagnosing bladder cancer and used for screening and checks. I've been fortunate enough to use this as well in an emergency situation where I'm sure we've all come across difficult catheterizations in the middle of the night. And often the only option is either a suprapubic catheter, or if you're fortunate enough to have an emergency operating theatre that can facilitate doing an emergency cystoscopy. These actually provide an alternative where you don't need a stack or a light source. You can go to the emergency department or a ward or intensive care, and you can do a procedure such as removing a foreign object from the urethra or a trapped stone, or even putting a catheter in. So if we go back to reusable flexible cystoscopes, although they are excellent, they do require a lot of maintenance. So they're known as a semi-critical device. So that means they require a high level of disinfection and sterilisation. And this is quite a long process. And in order for this process to be done, you need a dedicated nurse or a technician who has been trained. You need all the equipment to do that. And it can be very time consuming. And often in a list of doing cystoscopies, you have a limited number of reusable scopes, and there is often a pause whilst the scopes are cleaned. Two papers actually looked at how time-consuming this could be in just getting things ready. And one paper showed that the iCRIS system only took a couple of minutes, really, whereas the reusable scope, which meant setting up the equipment, the stack and everything, took 14. And another paper by Fan et al. Showed a very similar difference. So the literature. There's quite a bit out there, considering this is relatively new technology. And I just want to reinforce that initially, the iCRIS system was designed as a single use for removing ureteric stents. Now, it was important to establish if actually this is comparable. And this paper here by Talso et al. Shows that compared to other digital or even endosheath reusable sheaths, that is, they have equivalent vision. The water flow was surprisingly better when the grasper was engaged. As we all know, when we use a reusable flexible cystoscope, once we insert a grasper for a stent or do a biopsy, our flow it decreases, whereas they found in the iCRIS this wasn't the case. The only problem was it was a slightly narrower field of view, but they felt that this didn't impede at all the ability to remove the stent. This paper by Wong et al. Looks at the UK's first experience with the ambuscope, and they looked at 20 patients, and they looked at a wide variety of things, including overall costs and patient outcomes. They did a questionnaire for the patients, and 95% of the patients preferred having a disposable flexible cystoscopy compared to a reusable. They also found overall the cost was better with a disposable. This one is looking at Osiris. It's got slightly more, it's got 162 patients. And again, what they showed was it was safe and efficient, just as much as a reusable. And there was a potential cost saving because they were using it in an office room rather than an endoscopy suite or a theatre. This systematic review by Ahmed Adam et al. Gave a nice summary about how this is impactful in our COVID-19 era, particularly when we're trying to minimise using precious resources such as theatre personnel and the requirement of less support staff, as this is essentially a single surgeon or clinician use procedure. However, having read all the other papers, they felt that the overall costs and the utility of this device was very much dependent on what the individual service requires. Interestingly, this paper by Sayam et al., published in Nature Research, took a off-license use of Osiris system, and they reassuringly found that they had no difference in the detection of bladder cancer. And this systematic review by Hughes et al. Looked at the ureteric removal system, particularly focusing on cost, and they found that the overall it was a safe and alternative to reusable cystoscope and was cost effective. Now, when we're talking about costs, it's really important that you're not just focusing on the initial cost, which is just purchasing the cystoscope. It's also purchasing everything else, so the stack, the cleaning, the equipment, your training of staff, and then you've got the continuing costs, so the maintenance, the reprocessing, the fact that you have waitlist times that in England and the UK you can get fined for if you're not hitting the right targets because you're using endoscopy rooms for ureteric stent removals, and also room availability for other resources. When I've looked at the literature, there's quite a variety of costs, really. Beebe et al. Found that the reusable was cheaper than the disposable Osiris by about $38. Fan et al., when they looked at it first in 2018, found the reusable was cheaper, more expensive, and then became more expensive back in 2021. Donato et al. Found that if you take into consideration the fact that our reusables do break, particularly if you're using instruments down the channel, which have more prone to breakage, all those repair costs come up to about $23,800, and that was completely removed when using just the disposable. And 3 papers found that overall the disposable was more cost effective. However, interestingly, I found this paper that focused on what I think is probably more important, is that it looked at high volume and low volume urology practice, because not one size fits all. And actually what they noted was that if you're in a high volume centre, then it is cheaper to use a reusable cystoscope compared to disposable. And they looked at about 1,984 patients. Whereas if you're in a low volume centre, the reusable is actually cheaper as well. So looking at carbon footprint, in the UK, the NHS carbon footprint is huge for the NHS. It's about 6.3% of the entire UK carbon footprint. And needless to say, we're all trying to reduce single-use plastics, and a disposable cystoscope is that. It is a disposable single-use plastic. The companies are trying to net zero their plastic wastage, but it's still there, and they still haven't hit that goal. Reusable cystoscopes, however, do have a very large reprocessing footprint. And what I mean by that is that they have a large cost for the water they use, the solid waste, the repackaging, the reprocessing. That costs a lot and has a large CO2 impact. Ku et al. Looked at that, and they actually found that this single-use flexible cystoscope was significantly larger in terms of carbon footprint compared to reusable. And the largest part of the reusable flexible cystoscope carbon footprint was the reprocessing. And quite rightly, they suggested that could be reduced in the future if you replace it with a renewable energy source. However, Davis et al. Said that they were pretty much comparable. Now, they didn't look at flexible cystoscopes, they looked at ureteroscopes, but a single-use ureteroscope had a carbon footprint of 4.43, and a reusable one had 4.47, so pretty much the same. So thank you for your attention. I hope you found that useful and insightful, and an exciting adjunct to our urology practice.
Thank you, Madeline. That was a very interesting and in-depth presentation, and thank you for addressing all the questions, at least whatever I have in my mind. And I'm certainly quite convinced in few areas, like for example, patient attending an outpatient clinic who needs a stent removal rather than waiting for another 3 to 4 weeks, and also not taking up the space which is required for the cancer follow-up or new cancer diagnosis, etc. And to a certain extent, if the carbon footprint is nicely balanced and cost also is quite acceptable when we compare to the reusable scopes, yes, there is a definite role. And during the COVID, we have used plenty of AMBU-based flexible cystoscopes for clearing our waiting list. And yes, it has a very big role. There is no doubt in that. Next, and the last presentation is on the nuclear imaging technology from Hakim. And we also have our intervention radiology consultant, Salil, who will be adding his inputs in the end of the presentation. Hakim, floor is yours. When Hakim is sharing his slide. Yes, Hakim, yeah, go ahead.
Yeah. Good afternoon, and thank you for the director of the program and for the Mr. Ananda for giving me this opportunity to discuss radionuclide imaging in benign urological disorder. I will start by some definition. Isotope elements that all have similar number of protons but different of neutrons. Radionuclide isotopes are in a stable form and lose their energy with time. This energy could be used for diagnostic imaging or for radiotherapy. Radionuclide isotopes act as a tracer and combine to other chemical compounds, which manipulated by the cell and organ in a specific way. This combination is called radiopharmaceutical compound. The radiation emitted from this compound measured by specific gamma camera and translated by specific software to be presented as image curves and value. The choice of pharmaceutical, either mercury, DMSA, or DBT, depend on the renal function or the clinical problem needed to be investigated. Agents that clear from the body by glomerular filtration are useful to assist the glomerular filtration rate, like chromium A-data and DBTA, which 90% of them excreted by glomerular filtration and 10% bind to the plasma protein. MAG3 is a tubular agent, 95% excreted by tubular secretion and 5% by glomerular clearance. DIMSA is cortical agent that bind to the proximal convoluted tubule, and it is a useful agent for assessment of renal anatomy and differential renal function. Technetium-99 is the most commonly used radiotracer because it doesn't have any harm on the body and our pharmacological action. Low energy, quality of image is very high, not toxic, has no immune response, and can complex with different agents. Has short half-time, about 6 hours, and it produced from molybdenum accelerator. Indication of urological radionuclide study include assessment of differential kidney function like stone, tumors, donation, and nephrectomy for other benign disease, assessment of pelvic junction obstruction and obstructed ureter like megaureter, pyelonephritis and renal scarring, congenital anomaly like renal agenesis, ectopic kidney, and hypertrophied column of Bertin, and multicystic dysplastic kidney and duplicated kidney. Renal transplant imaging actually it used to differentiate between acute tubular necrosis and acute rejection. Assessment of vesico-ureteric reflex and assessment of renal artery stenosis. Renal radionuclide study include MAG3, which is mercaptoacetyl triglycine renogram, which is the diuretic renogram, is the most widely used and is preferable over DTBA because and it used in diagnosis of the upper tract obstruction and differential renal function assessment. And it is better than DTBA because it is easily prepared, better visualization of the renal parenchyma, and better quality of image, and more accurate assessment of the renal function in the case of poor renal function, as it depends on the tubular function, not on the glomerular filtration. Preparation of the patient is very important to decrease the false positive or false negative cases for anti-need hydration, empty bladder before study to avoid reflux, catheterization in some patients. And the position could be in sitting, supine, or prone position, followed by intravenous injection of radiopharmaceutical, then injection of the diuretic 0.5 milligram per kilogram of furosemide. And there are different protocol for injection of the diuretic. It could be F20, which means injection of 20 minutes after the injection of radiopharmaceutical, but this is result in about 50% of equivocal cases. And to reduce this, it can be injected 15 minutes before, what we call it F-15, or F0, both can be injected at the same time. After that, we can start looking acquisition of image every 1 to 3 seconds for about 1 minute, followed by 30 to 60 seconds for about 25 to 40 minutes, followed by evacuation of the bladder at the end of the study to avoid pelvic organ retention. And at this moment also we can take another image. This table actually show the difference between the renal handling between the DTBA and the MAG3, and it show that actually the study of the MAG3 is longer than the DTBA because the DTBA depends upon the glomerular filtration, which is faster than the tubular secretion, which makes the study shorter. The result of the study can be represented as curve, value, and images. The curve usually consists of 3 parts. First part is the vascular phase, take about from 0 to 10 seconds, followed by second phase, secretory phase, about 10 seconds to 5 minutes, and depend on renal handling of the agent, followed by excretory phase, which take about start from the 5 minutes onward, and the activity start to decrease in the kidney and to increase in the bladder. Important value from the study actually include the big activity time, normally between 3 to 5 minutes. Differential function normal is 45 to 55%, and you have half time, which is the time required to wash out 50% of the tracer activity at the kidney. If it is less than 10 minutes, this means it is non-obstructed kidney. If it is between 10 and 20 minutes, it is equivocal result. If it is more than 20 minutes, it will present high-grade obstruction. In the term of the curve, actually, we suspect to found 4 curves in this study. At the top of this slide, we show that the normal curve, which is rapid uptake and rapid washout of the tracer. On the left side, we show here the obstructed one, which show rising of the activity without washout. And at the bottom, we found that the type 3A, which is hypotonic, and show rapid washout after the injection of the aortic. This means this is not obstructed, and this is actually dilated pelvic calyceal system. On the right side at the top, we see that this is equifocal type 3B with continuous increasing the activity in the kidney, and after injection of the diuresis, there is mild excretory phase. It could be due to impaired renal function or hypofunction of the kidney, or due to partial obstruction. And here at the bottom of the right side, we can see that type 4, which is called Omi's sign. And after injection of the diuretic, there is rapid washout, but start again to increase the activity at the kidney. And it could be due to reflux or due to hypofunction of the kidney. And to decrease this equifocal cause, as we said before, we can inject the diuretic more early. In the term of the picture here, we can see this is one type example of the study. On the right side, we show here both kidney are normal function, they are comparable. And on the left side in the picture here, we can see that the image at the top, they are similar uptake of both kidney, and at the bottom we see there is similar washout both kidney. This is another example of the obstructed kidney on the right side. For here in the right side, we see the curve of the right kidney. There is increasing the activity without washout, which confirmed by the image on the left side. There is delayed in the uptake of the tracer of the right kidney and delayed the washout. We can see here at the bottom of the study. Also, positive result can be result from dehydration, high-grade reflex, massive pelvic calyceal system dilatation, and false negative can be result from renal immaturity, especially in children and neonate, or poor renal function. And to increase the specificity and sensitivity, actually we need, as we said before, the preparation, which include hydration, and sometimes we need to give eye fluid for the children, empty the bladder before the study, change to upright position if done in supine position, and take another image. Catheterization needed in case of reflux, ureter extended patient, and in case of high storage pressure bladder like neurogenic bladder, and low-lying pelvic kidney may be obstructed by, might be scared by the bladder. DIMSA scan, which is the mercaptosuccinic acid renogram, which is static study, which and the DIMSA is cortical agent, so it is used to evaluate children with pyelonephritis and the extent of renal scarring in the children and adults in case of chronic pyelonephritis. As compared to the MAG3, actually in the term of the differential renal function, MAG3 is a good agent for measuring differential renal function, but this is if the kidney located at the same depth in the anterior posterior plane, and morphologically they are similar. However, DIMSA should be considered if they are not located in the same depth, or if one kidney is rotated. Also, if there is a more function kidney and we need more accurate study, the DIMSA is preferable in this situation. After injection of the radiopharmaceutical, image taken after 2-4 hours. And this is here example of the study. On the left side, we see the normal both kidney, and in the right side, we saw here actually the left kidney show phototonia with a cold spot in the polar area of the kidney, which represent acute pyelonephritis. This is another example here, show that renal scarring actually in the right kidney, which show irregular outline and smaller size of the kidney with cortical defect. Another example for the anatomical study of the kidney with DIMSA scan is multicystic dysplastic kidney. And to differentiate actually this condition which from other cystic disease, DIMSA scan can be used with high accuracy. And because the renal parenchyma are dysplastic, actually it doesn't take any tracer, and which are very clear in the study. Radionuclide cystogram, actually radionuclide cystogram indicated in some situation, for example, evaluation of children with recurrent urinary tract infection, follow-up after initial voiding cystourethrogram and the reflux, assessment of the effect of surgery, and screening of sibling of reflux patient. This table actually compare between the standard micturating cystourethrogram and the radionuclide cystogram. Radionuclide cystogram, there are two types, direct and indirect. Direct means injecting radiopharmaceutical through Foley catheter to the bladder, and indirect means that injecting the radiopharmaceutical through intravenous line, and then we do for the patient the urotechnology followed by micturating cystourethrogram. Regarding the age, actually, it is very important for the indirect radionuclides to be considered because it needs cooperation to order the child to pass urine spontaneously, so that's indicated in the patient more than 3 years. Invasiveness, actually, it's more, it's less with indirect because we don't use Foley catheter, and radiation burden, actually, it is high in the micturating cystourethrogram. Regarding the grading, actually grading the reflex, it is more accurate in the standard micturating cystourethrogram. It can visualize the pelvic cell system more better. And the sensitivity actually is better for the radionuclide study. Renal function actually could be assisted in case of indirect radionuclide cystourethrogram. This is an example of the study here. On the left side, we show grade 1 reflex, in the middle grade 2, and on the right side grade 3. Thank you.
Thank you, Hakim. That was a quite in detail presentation, and thank you for bringing in all the pictures and images which were quite informative and very useful for the exam preparing candidates. And now we will try to answer some questions from the participants. Can you stop sharing, Hakim?
Yeah.
Thank you. May I invite all the faculty to switch on the camera so that we can answer some of the pertaining questions from the participants. Rajiv, the first question I have for you is, now in some institutes, we are using the portable shockwave treatment equipments. We know that the efficiency of the portable equipment will be never equivalent to the fixed equipment, which is much more robust. What is your view in that? Is the difference in the cost is worth trying?
Like if you have in remote areas where a fixed shockwave lithotripsy is not possible, this transportable lithotripsers, as it is known as the second generation ESWL machines, are worth using. But the thing is that in India, I am to say there are few places where people carry these portable lithotripsers in vans across to rural areas because there are no appropriate setup for fixed machines. And it has been found to be quite effective, but the workload on transportable lithotripsers, if you compare to these fixed lithotripsers in major centers. But for managing single stones in upper tract, in ureters, upper ureters, and the kidney stones, this has found to be quite useful because this uses this dual pulse focus systems, and it can be used safely and effectively. And the major concern of cost, that overweighs the fixed ESWL machines. Especially this is being used in many parts of Karnataka, Kerala, and the North Indian areas. In remote areas, it is being used quite commonly in India.
Thank you, Professor Rajiv. That's very useful. Next, I have a question for Professor Hamad Akhtar. Nice presentation. Thank you for the recording. Thank you for the small videos, which is very informative. My question is regarding further miniaturization like micro PCNL and ultra mini PCNL. What is your experience in that? Are we really stretching a lot and it results in quite a long procedure length and also sometimes resulting in leaving small dust particles like post ESWL scenario? What is your view on that?
Thank you very much, Ananda, for this nice invitation to be a part of this group. question about further miniaturization. We have already 4.85 French nephroscope, which is probably the finest that we can go. I agree with you that the finer that you go, the issue is maneuverability of the equipment, so that moving from one place to another, particularly in kidneys which have been operated before. So the advantages would be lost, because what you are competing with is the RIRS. Now, RIRS is able to go to various helices. It will be able to fragment. The real advantage with micro or miniaturized PCNL in comparison with RIRS, that it is able to clear the stone at the same time. So ultra mini PCNL and super mini PCNL have this ability that there will be a continuous suction as well as irrigation system, which allows in a wider bore outer sheath, which allows all these stone fragment to. So I agree with you that further miniaturization of these equipment is going to make it a more tedious process, and stone clearance within the first week of procedure would be low. And we know that this dust settles down in the lower pole calyx. They would aggregate again, and they sometimes would not clear with time. So this is probably where we are. The further improvement in technology is really not making it smaller, but making it more efficient, so that the stone clearance is guaranteed at the end of the procedure.
Thank you, Professor. Thank you. That's very useful. I think we are in the correct stage where we got the good equipment with an acceptable size and also not resulting in too much of bleeding or increased track width, and at the same time we are able to completely clear the stones. And I think in my practice I still believe the Storz mini PCNL set, which is 16.5 French, is like a optimal size, not getting too miniaturized, at the same time not giving a very big scar. Thank you for your input. Madeline, I have the next question for you. You had quite in detailed discussion regarding the disposable scopes, especially with the cystoscope point of view. What is your view on the disposable ureteroscopes? And again, the cost difference is there, and the vision difference is there. Do you think the disposable ureteroscopes will stand the long-term outcomes?
No, it's a great question. I think the ureteroscopes have a role as an adjunct. I don't think they'll replace them, but I think they're just like with the flexible cystoscopes. I think that there'll be a useful extra bit of kit that the urologist will ask for as and when needed. So just like with our guide wires, if we're in a tricky situation, we ask for a different guide wire, and I think that will be what happens with the ureteroscopes. They have a better angulation than the reusable. So I think if you're planning your surgery and you know that it's going to be a tricky angulation, then I think that's when you can say, look, have we got the disposable on the shelf for us? There's lots of positives with it, but I think the costs still haven't quite been even out. I think another thing that will happen is that when more and more competitive scopes come on the market, costs will drive down. So I think that it will probably get cheaper. I'm not convinced it's going to replace it forever, but I think it's certainly a great bit of kit. That's fair.
Thank you, Madeline. Professor Ahmad Akhtar, you want to add anything? Is there any role for these disposable cystoscopes or ureteroscopes in your country, and what is your view?
Well, further to what Dr. Moore said, the disposable thing is taking a place even in the developing countries. In my own practice, I found that these disposable scopes are useful because we started flexible ureteroscopy way back, about 10 years back. And the first scope that we had was 20,000 euros. And after 12 procedure, it was back to the suppliers. So the hospital was very unhappy with that. The Chinese flexible digital disposable scopes are quite cheap now, and we have scopes as cheap as $500. So that makes life quite easy, and you're more confident to train your residents because you're not really afraid about the scope breaking down and 20,000, 25,000 euros down the drain. So I think that there is a place, and I agree with Dr. Mood that definitely in a certain situation you need to have those reusable ones, but you need to have the disposable ones as well for certain situations. So horses for the courses.
Yeah, well said. I think as we start using it, I'm sure that the price will be more competitive and availability also will be there. And there is definitely a role. For example, in my situation, we don't want patient anesthetized, prepped and ready. And when we open our reusable ureteroscope, it has failing the leak test. And then we are held up in a very difficult situation where the disposable scope in the shelf will come quite handy. And from the patient point of view, I think storing few in the shelf is really useful. Salil, I'm coming to you for the next question. I'm going to ask a question which is not very medical, but more of like a population oriented question. For example, the ablation of the renal tumors. In some places we have radiofrequency ablation, some places cryoablation, and it appears something like a postcode lottery. And we know that some energy sources are always better than the other sources. What is your view as an intervention radiologist? Do you think that the better energy sources should be available, at least well dispersed, so that it's available for the most of the country? Or do you think that there is not much difference in the outcome and it's just the choice available?
Thanks, Ananda. Thank you very much for the question. So, as I said, you're right that even in a situation where we consider as a uniform healthcare throughout the country, you would always find some disparities. But the disparities may not necessarily be economic. There'll probably more be a case of operator familiarity and things like that. So, for example, in places that I know where they are using radiofrequency ablation for renal cell cancer, it's probably because that's the device that they're familiar with. Now, obviously, when I said RFA is more of a old technology, microwave is a new technology, maybe I was being a bit harsh on RFA at that time, in the sense that if you know the limitations of your technology, if you know how to use it, then it is definitely a good technology to use. So, for example, in our situation in UHB in Birmingham, we have our sister hospital, Birmingham Heartlands Hospital, where one of our colleagues uses RFA for kidney ablations. We, just down the road, we use microwave and cryoablation. Now, we have very set criteria based on the renal tumor size and some other criteria such as proximity to hilum and so on. And we have a very good working relationship where they assess for radiofrequency ablation. And if they feel it is not suitable, it is immediately referred over to us for consideration of cryoablation. So really, in my head, RFA and microwave are the two like for like. And RFA still is a very useful technology if the operator is aware of its limitations and not trying to do too many high-flying things with that. And microwave, when I say it is a more newer technology, it is newer, yes, but there are within reason. So if you know your technology, you can do quite well. So yes, there are differences in availability in the postcode, like you said, but when you go past the local trust funding and so on and so forth, it really does come down to operator familiarity and their ability to use the machine for the best outcome.
Thank you, Salil. For example, in my trust, we have only access to the RFA, but we know that at any time, if we need a cryo or microablation, you are available and we can refer you to a tertiary center. Thank you for that. Hakim, my next question to you is the radiation injury or the radiation dose for the radionuclide based imagings. What's your view on that? You are muted, Hakim.
I'm sorry. Actually, this is a very nice question. We found it daily from the patient because they know from this radionuclide study, maybe there is too much radiation and they are afraid from this study actually. But actually, if we inform him that the radiation from this is very low, if what we call it the effective dose, which measure the absorbed radiation of the body from this radiation, which measured in the by the unit of gray, which we call about 1 joule absorbed, and it depends upon the type of the pharmaceutical used actually. It's very low and it depends. We've calculated and it's measured in millisievert actually, and it's very low. If we compare MAG study with X-ray QB, maybe it's the QB is more than it. With the MAG 3, it's about 0.5, I think, millisievert. With the DIMSA scan, it's about 1.5, which is a very low dose, and it's safe on the body actually.
Thank you, Hakim. Yeah, the dose is less, but still there is some dose. That's very important.
Yeah.
Emika, thank you for joining, and I hope your on-call is not bad, and very nice to have you in the panel. My question
Thank you,
for
Anand.
welcome, and my question is for the talk of the town TFL, thulium fiber laser. At one point, they say that TFL is the ultimate answer. It's going to replace the older thulium and even the holmium. But then slowly we started getting the publications like ureteric injury due to the thermal effect, and then the TFL also has some disadvantages. What is your view on TFL, which is the newest kid in the market?
Yeah, thanks very much for organizing this meeting and for the opportunity. To your question, so thulium laser fiber is one of the new technologies. The proposed advantages is lesser retropulsion and also achieving high frequencies in terms of dusting. However, there's been advances as well in the holmium laser with the Moses technology that I talked about, with similarities in terms of efficiency with the thulium laser. The thulium laser, I think, because it's newer, is slightly more expensive, if I'm right, compared to the holmium laser. And there's also concerns, as you raised, about thermal injury because of the penetrative depth of the thulium laser. But I think, just like every new technology, time will tell as we get more evidence and more data. But my speculation is that there will be a role for both. In terms of, you could have both if your trust can afford it, or, everyone's pretty much familiar with holmium. There's long-term data with regards to that. And as time goes on, we will get more understanding with regards to safety of thulium laser. But it is efficient, it achieves higher frequencies, very excellent in dusting, and I think there is definitely a role for it moving forward.
Thank you, Mika. Thank you very much. I'm very sure that thulium fiber laser has a good role in the places like a renal pelvis stone or in the bladder stone, but in the ureter, the operator should be very cautious, and the temperature raised should be very, very cautiously observed. And since the fiber is also so thin, there will be a good irrigation, and using just a normal temperature saline, not the heated saline, will be also quite useful. Thank you very much for all the participants. It's too late for the South Asian country faculty and also the participants, and I hope this session is very informative and very useful for not only the exam going residents and also for the practicing clinicians. Hopefully we will meet again in the last week of every month, and we will meet again with BPH technologies in the month of the May, and you all will receive the information. Thank you very much, and thank you for your time.
Thank you.
Thank you.
Thank you.